So a lot of folks have this impression that they need to do everything for everybody, no matter what. Physicians do not have an obligation to provide fetal care. If the care is clearly not going to benefit the patient, you are well within your rights. Now, it can get very sticky, but you are well within your rights to say, no, we can't go there. For instance, in my residency, we had a child that was dying of osteosarcoma. He was within days of death. The mother insisted that we put him in the PICU when he was deteriorating rapidly and intubate him. The PICU refused, and they were well within their rights to refuse. There was nothing they were going to do for this child, no benefit whatsoever. So at least keep that in mind. You are not required to do everything, but you need to weigh it very carefully if you tell people that you're not going to do everything.
And that actually was a question that was emailed to me about futility, and are we required to continue codes or other interventions that we know aren't going to work? So either someone that's coding or someone that's, as Jim describes, just very, very sick, and we know that we're not going to reverse the underlying process. And I think that's really, really important that we realize that you're not obligated to do things that are completely futile. If you know that trying to get a pulse back on this person is not going to change the underlying fact that they are in the process of dying, and that is a tough thing to know, to be honest, especially in the acute phase. But if you're aware that you can't fix the underlying thing, then no, you don't have to intubate that person that's hypoxic, that has end-stage lung cancer with nothing to offer them. But you have to be very careful with that because it is a very touchy issue for families and a very touchy legal issue because they're going to be like, why didn't you intubate them? You have to be very, very good at your documentation and your communication with family about why it is that you don't want to put a lung cancer patient on a vent to watch them wither away.
Like I said, at all costs, remove the decision-making burden from the family. All right, put that on you. All right, I think you'll find a lot of times they're going to go with you. Okay, they're falling behind you.
I am a huge proponent of shared decision-making, and I think that you need to talk with the family. But as Rich points out, it is grossly unfair to talk to the child of a patient and say, like, I want you to be the person that makes the decision to turn off the vent or not intubate them or say DNR. I think that that's really unfair to them. Our shoulders are broad. We do this every day. They do not. They've got one mother. We've got thousands of patients. And I think that assuming that role of here's what I'm recommending to you, seeing that this person has end-stage lung cancer and they're not likely to benefit from the things that we're saying, our recommendation is that we don't try to do chest compressions or intubate them. Does this sound like something that is matching up with what their wishes would have been? Now I've removed it from, okay, you're the patient's son and you're having to more or less kill, quote unquote, your mother or father, to this is what the doctor is telling you and removing that burden from you so that you're not the one that has to say, yes, we're not going to save my mother. It's a totally different conversation of, look, it's not going to fix the fact that we have this terminal cancer.